I think we move into the questions part now. Can everybody hear me?
Yeah.
Okay, there's a question from the attendees from Dr. Sonia Danoff. I just need to, oh, that's already gone to Deji. This was about survival in IPAF versus ILD. So you've answered that question, Deji. I had another question for you, Deji, which are there any markers of progression that are common across the different forms of ILD? Because in your presentation, you looked at different prognostic markers, but is there anything that's sort of common across all forms, or do you have to somewhat tailor the markers that you use to identify progression for different conditions?
Yeah, that's a good question, Colin. There are diverse markers that seem to transcend what we call those distinct categories of ILD subtypes. So markers that are common across board could either be radiologic markers or sometimes serologic markers. When we think about radiologic markers on CT scan, things like ILA, so interstitial lung abnormalities. There was a recent publication in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine, that seems to suggest that patients with interstitial lung abnormalities have a higher risk for progression and actually, frankly, developing disease down the line. These seem to be more prominent in those who had family members who have a distinct diagnosis of ILD. So patients who have interstitial lung abnormalities who now have family members with ILD have a higher risk of progression to developing frank interstitial lung disease. In terms of serologic or blood-borne biomarkers, we think about cytokines and sometimes proteins like MMF, MM7, matrix metalloprotease 7, MMP7, and other cytokines as well that seem to identify those who are at a higher risk of progression than others. Interleukin 10 is another example like that. And so there is a host of markers that seem to transcend the borders of distinct ILD entities that can be helpful for predicting a clinical decline during the clinical course of patients who have interstitial lung disease.
Thank you. And a question for Mel, which is somewhat related. So in view of the different groups of patients that, the prognostic markers can identify progression, should those patients be monitored more aggressively or in different ways if we could identify them using remote monitoring? I mean, this might be a particular issue where there's geographical issues with getting access to specialist centers.
I think it would be hugely helpful for subgroups and cohorts who are more at risk to be targeted for remote monitoring, just because you have that sort of flexibility and agility of response to react and act on earlier drops in FVC. And we know that all declines in FVC could be potentially prognostically important, and also in picking up acute exacerbations. So yes, I think if we're starting to identify with markers, biomarkers, or other radiological markers that there are certain groups that are at risk of progression, it would seem sensible that we use every tool that we have in our toolkit to monitor those, and that would include remote monitoring with real-time reactions to the data.
Mm-hmm. Mm-hmm. And Andreas, I have two questions to you. One I think is quite a quick one. In the registry, the new registry that you're planning is obviously going to run for quite a long time, and new treatments will be entering into clinical trials over that time. Will such patients be allowed into the registry if they're already on an existing treatment of a new therapy? I can't hear Andreas, actually.
Sorry, can you hear me now?
Yes, yes.
Okay, so sorry. So the answer is yes, will be possible, and of course as far as the treatment information of the treatment is available, this is going also to be captured in the parameter set.
And the other question, there's clearly a lot of focus on collecting biomarkers and samples for biomarkers across a huge range of parameters. But how important is it to have long-term, and you did refer to this a little bit, how important are long-term data on symptoms, markers of symptoms, or quality of life scores as part of the biome of the patient in the registry? Because sometimes, of course, you can see a disconnect between a patient's perception of their condition and something you can measure.
Yeah, you're touching obviously a very important issue, which is how long can an observation period be to allow a patient to safely compare her or his own consideration of the health status. I guess that there is a kind of a natural limitation, and there are some data from our registry supporting that, for example, comparison of health states with 1 year distance in between is difficult because patients just don't remember precisely how they felt 1 year ago. And obviously this is also going to be, of course, part of the answers that we aim to get in this registry structure. I'm a little bit skeptical. I think short-term changes will certainly be easy to be captured also by patient-related outcome parameters. But if you're talking about year-long studies, I think there are natural limitations of this kind of parameters.
A question for Rebecca. Rebecca, do we have data on how frequently or how willing patients are to do frequent measurements of lung function or pulse oximetry over fairly long observation times? I know we had good adherence in the acute COVID program, but what do we have from some other programs?
Yeah, typically what we've seen from centres that we're working with is that they have their patients do the spirometry weekly, but some centres have more frequent use of spirometry and oximetry, and some have longer. So just at the virtual consultation timelines. And then also if they are noticing a deterioration, that they can have the patient do the spirometry at home and be able then to decide while the patient's at home whether they bring them into clinic or whether they're continuing to manage their condition at home. But yeah, we do have good adherence levels, and like you said, in the COVID application as well, we have strong adherence levels.
Thank you. So I see, Seja, you have another question which you're busy answering on typing, which is on tumor markers being shown also to be marked by ILD. Do you think it's going to be feasible at some time in the next little while for them to be used possibly to look at, propensity to progression?
Yeah, I like to take an optimistic view to that. I do hope at some point that some of these biomarkers will be ready for prime time. The challenge is that the practical application of many of these biomarkers remains, they remain confounding because of their primary association with other disease entities. So, for example, Dr. Mehta was talking about CA19-9 and CA125. Those have been associated with cancer, right? Particularly the pancreatic cancer forms. And many of these malignancies do coexist oftentimes with interstitial lung disease. And so the underlying association with primary comorbidities could confound that association of the biomarker with interstitial lung disease development. And so that really becomes challenging to implement in clinical practice because you have to consider other things as well. I do, however, think that our ultimate goal, what we should strive for, is biomarkers that identify the risk of developing disease, not progression. So our goal should be to prevent the development of ILD down the line. And so if there are biomarkers that help us identify who's at risk, in a way that's actionable to prevent development of disease. That should be our focus. That should be what the field should, pay attention to over the next several years to help us stem the ugly tide of poor mortality that's associated with this disease.
Okay, well, thank you to our speakers, and thank you to everyone for attending today's webinar, Data-Driven Approaches to Identify Progression and Optimize Outcomes in Interstitial Lung Disease. If you have any other questions, please email hcp@patientmpower.com. If authorized by patientMpower, the webinar will be posted to the ATS YouTube channel in about 2 weeks. On behalf of patientMpower and our presenters, thank you for joining us today, and have a great rest of your day.